So, have I got to introduce myself or somebody is introducing me?
Yes, I will be introducing you, sir. Now we are live, sir. So shall we start?
Yep.
Yeah. Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned professor, Dr. Chandrasekhar E. Dio Pujari. Sir is MBBS, MS, MCH, MSc, UK, FAANS, Professor and HOD of Neurosurgery at Bombay Hospital, Mumbai. Fellowship Director at the Department of Pediatric Neurosurgery at B.J. Wadia Children's Hospital, visiting consultant at PD Hinduja Gamma Knife Center. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is master gland, major trouble, unmasking pituitary tumor, and their ripple effect. Now, without any further delay, let me welcome Sir again at our forum and would like to hand over the session to him. Over to you, sir.
Thank you, dear. I thought that we'll just familiarize ourselves with some of the functions and what a surgeon can do in pituitary disorders. So, basically, the talk will be oriented towards rational management of pituitary lesions from a surgeon's point of view, but we'll cover the other aspects of treatment as well. The pathophysiology of pituitary disorders revolves around dysfunctions in hormone production, either excessive or deficient, due to abnormalities in the pituitary gland. In fact, if you look at ancient literature, right from Ramayana, and you will find it also in uh, Mahabharata, there are uh, references to endocrinological disorders, and that the fact that they may be related to some part of the brain. And that part of the brain happens to be pituitary, which is not really part of the brain, but it is stuck to the undersurface of the brain with what is called pituitary stalk. And the surroundings of this gland are equally important as much as the gland is. The below lies the paranasal sinuses, and just above lies the optic chiasm, hypothalamus, and then all the brain structures at the bottom, including the major cranial nerves. And blood supply to the pituitary and optic apparatus also comes from below. So the undersurface of the optic chiasm and the below part, or the part of the pituitary between the stalk and the gland, is very, very important for managing pituitary function. And you can see it in anatomical details on this cadaveric dissection, where you have injected some dye to show the vessels, that not only the nerves but even these tiny blood vessels are very, very important, and that's why surgery becomes tricky in this area. Diaphragma ocelli is actually what separates the pituitary gland from the uh, rest of the brain, from where the pituitary stalk goes down into what is called sella, just above the sphenoidal sinus. So why are we talking about this? I think it is not very well known that pituitary tumors are relatively common, and in United States more than 10,000 pituitary tumors are diagnosed every year. And in fact, the studies suggest that almost 1 in 4 people have a pituitary tumor without ever knowing it. Why I'm saying this is a study of one particular state, Salt Lake City in Utah, has written their experience in a community where they have shown that the estimated prevalence of pituitary adenoma is 16.7%, uh, including autopsy and radiological studies. If you think of only radiological studies, it is high as 22.5%. So I think when we talk about pituitary area, we need to talk about the sellar region, the area that is anatomically houses the pituitary gland and can develop in various type of tumors in adults and children. In adults, the overwhelming majority is pituitary adenomas, a few craniopharyngiomas, a few meningiomas, and some very, very rare tumors, which we need not even bother about, especially in adults. While though the cellular supracellular tumors form 10% of pediatric brain tumors, the pituitary adenoma takes a back seat. It are mainly craniopharyngiomas, germinomas, hypothalamic optic gliomas, and Rathke's cleft cysts rather than pituitary tumors themselves. Current pathological classification has undergone a lot of changes, and now we call them pituitary neuroendocrine tumors, and they are recognized by the histological subtyping as well as their hormone producing activity. So, what are the common symptoms? When the tumor becomes big, of course, headache. But even before the tumor becomes very big to cause raised intracranial pressure, you can get headache because the diaphragm sellae gets stretched. And diaphragm sellae is a very pain sensitive kind of a structure. And the pain is mainly felt retroorbital or frontal. Visual disturbances, the typical visual disturbance you get in pituitary tumors because it compresses the optic chiasm from below and in the center is loss of peripheral vision causing what is called bitemporal hemianopia. So I think it is not only general eye examination but perimetry that is important to rule out a pituitary tumor if you cannot find a definite eye cause for reduced vision. And double vision can also occur if the tumor goes into cranial nerves or cavernous sinus. And sometimes there can be sudden presentation because of what is called pituitary apoplexy, either due to sudden hemorrhage or infarction in the lesion. I think Khali is very well known to James Bond fans as well as probably who watch WWF. And acromegaly is what he's suffering from. He's taken a lot of time to decide that he wanted surgery because it was paying him to be acromegalic. But it doesn't work that way because acromegaly can cause not only enlarged hands and facial features, but it causes metabolic disturbances like accelerated diabetes, hypertension, and cardiac disease. Cushing's disease is also very, very difficult to control and is due to the pituitary disorder. And it presents with weight gain, moon face, dark changes of the skin, and hypertension. Prolactinoma is a very, very common tumor, especially in young people, and presents with secondary amenorrhea, irregular menstrual cycles, and infertility, and in late stages, even galactorrhea. Thyrotropinoma, gonadotropinomas are less common tumors, and we need not bother talking about them except for a few points which we'll cover on the way. The second way the pituitary tumors present, and many tumors are non-functioning, they are not coming from hormone producing cells, and in those you actually get hypopituitarism, and that presents with a general sense of fatigue, weakness, low blood pressure, reproductive dysfunction, and a person does not even know that he's suffering from something which can be cured. Diabetes insipidus can occur very, very rarely. More common is what is called SIDH, when you get hyponatremia, lethargy. What is the treatment? Treatment of pituitary disorders depend on specific condition and severity. Medication works in some lesions, especially very, very common lesion is if you have hypopituitarism, once you replace cortisol and thyroid, you find that the person can regain normalcy. And if there is no visual compression, you can probably treat that patient conservatively, even with a pituitary tumor. Surgery, of course, is important whenever the tumor grows big and causes optic nerve compression or causes hypersecretion. Radiation therapy is used when surgery is not successful, and lifestyle adjustment and ongoing monitoring is required lifelong for most of these patients. The American Association of Clinical Endocrinology has actually provided very good guidelines for hormone secreting and non hormone secreting tumors, especially hormone secreting tumors. Growth hormone secreting tumors, that is what is called acromegaly. You confirm that with elevated IGF levels and failure of GS suppression during an oral glucose tolerance test. Once you confirm that, then transfemoral surgery is the preferred approach for tumor removal, aiming for biochemical remission, which happens in over 70% of patients. Medical therapy is used if the person is unfit for surgery or if he is not cured by surgery. And there you use somatostatin receptors, dopamine agonist, and GS receptor agonists. Radiotherapy, if both treatments do not work, and long term monitoring is always required because you can get only remission, but recurrence can occur later on. Success Rates for acromegaly treatments: surgery is 64 to 70% successful. Medication can be successful in about 60% patients, 40 to 60% patients, and radiation therapy is also successful only in about one third of patients. So you can see surgery remains the mainstay of the treatment. What about Cushing syndrome? Again, late night salivary cortisol, 24 hours urinary free cortisol, and overnight dexamethasone suppression test usually help to diagnose the condition that it is pituitary dependent. And then you do the imaging, make sure that patient has tumor. And then again, the first approach is surgical removal. Success percentage is about 60%. If it doesn't work, then medical therapy and radiotherapy remains the last choice with long term monitoring. Prolactinomas is one condition where the diagnosis is not only by elevated serum prolactin, you need to have a serum prolactin level about 200 to make sure that it is a prolactinoma, because other disturbances of stalk can also cause elevated serum prolactin. MRI is necessary to make sure of the tumor size and location, and the treatment mainly is medical. Cabergoline and bromocriptine usually help in about 80 to 90% of patients. Surgical intervention is considered only if patient is not responding to treatment, and radiotherapy is used extremely in rare cases. So this is one patient who has a large tumor with prolactin levels of more than 2000, and you see that within about 6 months with cabergoline the tumor has virtually disappeared with normal chiasm seen, and patient regaining his vision completely. Prolactin levels were more than 15,400 grams, and they came down to like 15 afterwards. Non-functioning pituitary tumors, MRI is the primary imaging modality. Hormonal evaluation is necessary to see subtle endocrine dysfunction, and surgical removal remains the first choice of treatment. Even here, radiotherapy for residual or recurrent tumor. One thing which you must always remember, especially in young patients, is that hypothyroidism can cause hyperplasia of pituitary gland. There are some other disorders like hypophysitis, which can also cause, and there you will find that the stalk is also enhancing. So this girl actually presented with headaches, and with proper thyroid treatment, she is completely recovered with remission of the tumor. So let's go to the surgery. It's very, very interesting for surgeons how the surgery is developed, because way back in 1889, when it was first started, it was by the frontal route by craniotomy, and it was extremely difficult to reach the pituitary area and remove the tumor. So then his disciples decided to do it from the temporal craniotomy. They were also unsuccessful, and it took almost another 20 years before people realized that it could be done from below, and then various techniques from doing surgery from below were developed, and these consisted of various incisions around the nose to get to the sphenoid sinus and to the sella. And proper treatments actually started with Schlofer's lateral rhinotomy from Austria, Hirsch's endonasal from Germany, and Chiari's transethmoidal approach, and became standard with Cushing's sublabial transseptal approach. However, because of lack of illumination, lack of proper instrumentation, lack of X-ray, I mean X-rays were available, but fluoroscopy was not available. So lack of intraoperative localization, Cushing went back to doing transcranial surgery, and everybody went back to transcranial surgery, and there was a void for almost 30-35 years before the inferior approaches were brought back again. This is one of the transsphenoidal surgeries done by Cushing, and this is a patient with typical acromegaly. You can see how it developed and how it reduced after transsphenoidal surgery. So Cushing not only has the sort of honor of being the father of neurosurgery, especially in American neurosurgery, but also is credited with a disease, endocrinological disease like Cushing's, because he discovered it and he discovered the treatment for it. So the inferior approaches developed further. In 1956, the nasal speculum was eliminated. Then 1958, C-arm fluoroscopy came, and then the microscope came in 1967, making it a standard approach. So people started using transsphenoidal approach for all pituitary tumors. I had the opportunity to meet Dr. Hardy, who's considered the father of microsurgery of pituitary gland, and it was quite a learning experience how we progressed. People became more and more minimally invasive afterwards, and this was another variation where you need not have to lift up the nose or make a sublabial incision. You could just insert a speculum in the nose and you could reach the humor directly. However, the need for search of newer approaches was still continuing because of fear of meningitis, struggle for improved vision, and of course, the minimalism in neurosurgery had become trendy. And therefore, what came to our help is the precise localization of septations, their relationship with carotid arteries by several anatomical and radiological studies with high definition CTs and MRIs. And therefore, the endoscopic endonasal technique started in 90s. We started using it in 1996. The first paper got published in 1996 from United States, and very soon we followed that, and it involved only localizing sphenoid ostium, opening the anterior sphenoidal wall, opening the sellar floor, and then remove the tumor, get the tumor down with angled scopes, and then close it properly. And the ENT surgeon started helping us, making it easier for us to reach through the nose. So, a very simple thing, put an endoscope, make sure where the opening into the sphenoid sinus is, enlarge that opening, and then once you enlarge that opening, make sure you are there, and then open it further into the sella, and then remove the tumor as we are doing in this particular patient, and the whole tumor is removed. One-sided microadenoma causing, I think, acromegaly in this particular patient. This is a large tumor which was removed by that approach, but I'll show you better pictures later on. These are at the time when the cameras and the light source were not so good. Now we are working with 4K screens, we are working with HD cameras, and we are working with intraoperative illumination, which is also color coded, especially for fluorescence techniques to make sure that you are removing only the tumor and not the normal pituitary gland. So such large tumors could also be removed by the endoscopic pituitary surgery. Another one where we could remove it, these are done in almost 90s and early 2000s. And later on, we could do it even in children. This is a child with Cushing's, where you could see that there was a small tumor next to the cavernous sinus. By endoscopic transsphenoidal surgery, that has been removed. And you can see the dramatic effect. This boy, after 1 year, was unrecognizable. This is another boy presented to me at 12 years of age, and you could see the ACTH levels were high. You can see the microadenoma here, and this is being removed by, you could use the drill by this time through the endoscope. You are opening the sellar floor, and once you open that, you make sure that you are beyond the tumor on all the sides. Make an incision into the sella. You can see the videos, all right? And then the tumor is protruding out from the normal pituitary gland. So in a young boy, it is important also to preserve the normal pituitary gland, and that is being removed. And once this is removed, this boy has recovered. You can see the MRI recovery, and you can see the boy how he progressed further. I operated in 2008. He gradually changed his appearance, and this was after almost 15 years. He's an engineer in US now, and almost back to normalcy. So what are the advantages? I think several meta-analyses have shown that the endoscope was more efficient than microscope in terms of quality of resection and the endocrinological outcome, particularly for large tumors. It has also shown that in recurrent tumors, it was better because of wider exposure of sella. And then people have done various clinicopathological classification as to where you can achieve good success, where you cannot. And it depends on the size, invasion. And this is another classification which tells you the same, and it also talks mainly about cavernous sinus invasion, which is a big difficult area. But the analysis of anatomical variations of sphenoid sinus and ICA gave us a better insight into what can be done. And this is one patient, you can see a very large tumor. And you can see that you have to open not only the sela but also anterior skull base. Then you open the sellar floor, and then you are removing the tumor. You are almost going to the undersurface of the optic chiasm. Then you are going into the anterocranial fossa. You are removing the nodule of the tumor which has gone way in front. By this time, better instrumentation developed for endoscopic surgery. You can see that it is separated through a thin membrane, what we call arachnoid, from rest of the brain. And you can see that the whole brain, the frontal lobe, the anterior cerebral artery, all this can be preserved very well, and the tumor can be almost completely removed, as you will find on the post-operative MRI. This boy was 25 years when he was operated. He got married and he has now 2 children. And that is possible because with endoscopy you can even save the normal gland, which was all stuck at the top in this particular patient. What you require is something more than what you require for microsurgery. You require a vascular Doppler if you are removing tumor near the pituitary. You require cord suctions to go into the uh, crevices or corners, and you require something where you have to, without fixing the head, you get a good navigation. So these are the pictures which show that with navigation, with 2 surgeons operating, how you can remove the tumor. This is one girl where the serum prolactin was 900, large tumor. It reduced over a period of time, but when it recurred, then we had to operate. And here you will find that after drilling, you have got the tumor being removed. You can see the normal pituitary at the back. And once you go further and further, you are removing the tumor from almost inside the brain into the ventricle. And very soon you will find that the third ventricle is seen here. Front of the tumor is being removed by front uh, bent kind of suctions, and this is what is the third and foramen of Monroe. You can remove the tumor all the way up to the top, and you require Doppler to make sure that you are not damaging any vessels. You keep on insonating during surgery, making sure that you are not harming this area. And you need to properly study the MRI, put it in proper classification. Earlier, we thought we could not remove grade 3 tumors, but with endoscopy, it has been possible to remove. And therefore, the classification has also changed now. And you can see another case where I will show you how it can be removed. So you make a bigger opening. You make sure that you go along the carotid here. And then while removing the tumor, you will realize that not only you are able to remove the tumor from the sella, you can see the carotid artery here, and both sides the tumor can be removed, and this patient could be completely improved. So even the people who had first talked about the fact that a lot of cavernous sinus tumors could not be removed, they showed in their later studies with the use of endoscope that it can be removed. Another group in Canada which has proved the same, that the preoperative NOS grade tumor volume, tumor diameter are important, but it can be removed better with endoscopic surgery. And this is one patient in our local area where bilateral cavernous sinus invasion was there, but we could remove it completely with endoscopic surgery. So basically the idea, whenever it comes like endoscopic pituitary surgery, there is a lot of skepticism in it. Now it has become active acceptance, and almost most of the major centers are following it in India. Does it really help the patient? So there has been a survey done from 250 patients which has shown that rhinological recovery is typically rapid and relatively complete after direct endonasal surgery using both standard and extended approaches. Of course, I think there will be innovations, there will be progress, and intraoperative MRI is being used for complete tumor removal. Robotic technology is being used for complete tumor removal. But you must also understand that there are patient factors. So preoperative risk factors must be assessed. In a study of 5,000 patients, older age intraventricular extension, there is a more postoperative discomfort, apart from cavernous sinus, of course. And some people therefore use combined approach. We have found it not so useful because chances of infection increase, though we did it in some patients. So we do two-stage surgery now. Whatever can be removed by transfemoral approach, we'll remove, and then we'll follow up with a transcranial procedure to remove the rest of the tumor in functioning tumors. In non-functioning tumors, we'll put them directly to radiotherapy. This is a recurrent case of Cushing's, and now we can enter the cavernous sinus directly, like we are showing in this picture, and you could remove the tumor from both sides of the carotid artery. And this is a complete removal afterwards. This is acromegaly patient where you cannot remove. So the cavernous sinus component, if it cannot be removed, then we subject it to gamma knife nowadays, and that seems to be quite effective as well. So surgical outcome of functional pituitary tumor, 50% to 90% depending on the tumor type and surgical expertise. Microadenoma, acromegaly, and prolactinoma, you can get almost up to 90%. Cushing's or invasive tumors, you go down to 50%. And therefore, adjuvant medical treatment or radiotherapy is required. What are the complications? CSF leakage is the most common complication. It has reduced after the nasal reconstruction has become better. Recurrence rates are about 16%. Visual improvement occurs in almost 80% of patients. Tumor growth control, I think, is extremely important, and radiotherapy achieves that if surgery does not. And hormonal regulations must be controlled by giving supplemental hormones for several years. Nowadays, less invasive radiotherapy in the form of stereotactic fractionated and IMRT has come, and that is also quite useful in preserving pituitary function. So I think I will end by giving a few tips that medical treatment still plays an important role, especially in prolactinomas, residual or non-responsive GH secreting tumors and cortisol secreting tumors. I would also say that endoscopic endonasal surgery offers several advantages, like it is a minimally invasive procedure, patient is back to work in about 7 to 10 days, avoidance of brain retraction, improved visualization, faster recovery, preservation of optic nerves, and lower risk of nasal packing and infection. And I think the main problem today still remains is the diagnosis of pituitary tumors is often delayed because in non-functioning tumors, the symptoms are non-specific. The growth is very slow. Hormonal effects are not easily identified. And therefore, there are a lot of people feel that there is an incidental discovery and lack of awareness that it is such a common tumor. Success rate in India, I think we are fairly good, 80 to 90% success at most of the major centers. Type of tumor, of course, is important with size and location, and surgical technique is important, endoscopic pituitary being the standard today. Transcranial surgery in last 1000 patients, we had to do only 48 transcranial surgeries, so it has come down to almost 5%. Thank you for a patient listening, and I'll be happy for any discussion, questions.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah.
So the first question is, what are the common symptoms associated with pituitary tumor, and how do they vary dependent on the tumor type?
So I think till about 10 millimeters, the tumor remains confined to sella, and the only presentation we may have is some subtle deterioration of pituitary function, and that presents with just lethargy, etc., and therefore not very well understood by the patient. So many patients who come to us with hyponatremia, you find that they have pituitary tumors. So I think a thorough examination, especially the metabolic parameters as well as the endocrinological parameters, should be studied in such patients. If the tumor is about 10 millimeters, if it grows inside the skull, then the most common thing is visual disturbance. Now, many patients go to the ophthalmologist, and because perimetry is not done, they are not diagnosed. So, I think if you do not find a definite cataract, if you do not find a definite optic disc problem, then this patient should be subject to a simple test like perimetry, And if the perimetry shows outer field cut, I think you are very sure that patient is suffering from pituitary tumor.
Next up, sir, could you explain how pituitary tumor impact hormones production and regulation in the body?
Uh, See, the hormones are secreted by the hypothalamic pituitary axis. Most of them are secreted by some stimulation through the hypothalamus, but you get growth hormone secretion, you get TSH secretion, you get gonadotropin secretion, you get prolactin secretion, and FSH and LH secretion, all through this axis. And therefore, disturbance can occur very, very commonly. Specific cell types, when they get affected, they present as specific endocrinological tumors with hypersecretion, like acromegaly and Cushing's, as we discussed, which are the most common.
So there's one last question. Can you discuss the long-term consequences and potential complication for individuals who have undergone treatment for pituitary tumor?
I think there are two, three important things. Immediate postoperative, you need to make sure that the patient does not have any abnormal bleeding through the nose and CSF leak through the nose. If these two problems do not bother you for the first 3 to 5 days, then I think the healing is quite proper. Then the next question remains is some of them undergo metabolic changes like diabetes insipidus or SIDH. And you need to check their sodium for the first 3 days continuously and then after a week and 3 weeks, which we regularly do. Beyond that, long term complications if the patient is hormone deficient, of course, needs hormone supplementation and every 3 month follow up with an endocrinologist. I wouldn't think of anything else. If you have left a small tumor behind or even otherwise, I think you should probably do a 1 year, 5 year, and 10 year follow up scan to make sure because some late recurrences are known.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take-home message from your end?
Take home message, as I showed in my last few slides, that awareness is still lacking, not only in patients but even in doctors. I think once you realize that the pituitary tumors occur in virtually every fifth person in this world, you will realize that how common they are. So we have talked about some very less frequent symptoms, some very non-specific symptoms. These patients still need evaluation. And I think MRI has become so easy and hormone evaluation has also become so easy that we should not be missing on that. In terms of treatment, I think treatment is becoming more and more standard now and is becoming safe. So I do not think for fear of treatment anybody should be denied treatment. The last point is follow up. I think post op follow up needs to be prolonged, and imaging is part of it, but hormone evaluation is also an equally important part of it.
Thank you so much, sir, for joining us today. It's a pleasure to have you here with us. With your permission, I would like to conclude today's session. Thank you so much, sir.
Thank you, dear. Uh,